to talk about is how obesity is a chronic relapsing condition and how, as I said, medications are a small part of obesity management. What are the most important parts? I am the least important part of my weight management MDT clinic, and I say that all the time. How are we looking at achieving long term sustainable outcomes and avoiding disappointment? So, as I said, obesity is a chronic condition. It's almost a lifelong condition for most people. We don't lose weight and stay at that lower weight without a lot of effort. It takes a long commitment, compliance to lose weight and keep it off. It is a relapsing condition. So, we lose, yes, with calorie deficit, with exercise, with pharmacotherapy, we lose. But does it stay off? It does come back. So, remember, it is a relapsing condition and it's a multifactorial condition. There's a huge taboo, there's a huge social stigma associated with obesity, and that's something we have to challenge as well. Once again, very important point, obesity is not a lack of discipline, it's not a lack of control in eating food. It's a much bigger picture. So it's influenced by genetics. So we all have some genes, some of them are stronger predisposed to make us obese. Environmental factors, of course, the food and lifestyle, exercise, behavior. And in terms of behavior, I mean food psychology, having tendencies to emotionally eat, having tendencies to binge eat. And this is the most important part of our weight management MDT, to the point where I refuse, or our pathway is such that people don't come to me as a prescribing clinician before they see the food psychologist or clinical psychologist in the weight management clinic, and they've addressed all factors around emotional eating, boredom eating, stress eating, binge eating, past trauma, and it's very, very important for that to be addressed before we undertake any other interventions. So, food psychology absolutely important, and metabolic adaptation. So, our body is always acting against us when we are trying to lose weight, because our body thinks we are going into a state of starvation. So it gets up all the defense against us losing weight, and I'll go through that in a minute. But it's also important, it's just not about appearance or body image. It's important because we know obesity is associated with a huge number of medical or metabolic conditions like type 2 diabetes, cardiovascular disease, fatty liver disease, and even certain cancers, and many, many more. So it's important to manage obesity in order to reduce these risks. And there is actually a dysregulation of energy homeostasis. That is the definition of obesity. Not that you eat more, you're fat. It's a dysregulation of energy homeostasis because of our hormones and neuronal pathways working overtime. It's not just food and it's not just lifestyle. Now, when we look at certain populations, and I've put a slide on South Asian populations today because there's a disproportionate risk. We are at a higher risk of cardiometabolic problems and at much lower BMI thresholds. So, as you know, for white Caucasians, a BMI of over 25 is overweight, a BMI of over 30 is obesity. WHO recommends much lower BMIs for people from South Asian origin and also from Afro-Caribbean origins. So BMI of over 23 is overweight in South Asians, and a BMI of over 25 is classed as obesity. So much more hard work to do. And why is this? It's because these populations have a greater tendency to have visceral fat. So that's the fat surrounding the internal organs. And that is the fat that is implicated in cardiometabolic risk. So we need to address that. We need to bring that down. And South Asians have more visceral fat. So the fat that we carry around our abdomen is very dangerous. That's the toxic part that is increasing our metabolic risk. And as South Asians, we are more prone to have that fat. And of course, insulin resistance. So it is how effective the insulin your pancreas produces is in pushing the glucose into the cells. So these factors are predisposing us to a much higher risk. And of course, our culture is different. Food is a very important part of socializing, of showing affection, of celebrating, of, even if we're having a bad day, we go and pick up something to eat. It's that emotion. In addition to emotional, there's that cultural, social aspect as well. And family expectations, all those things come into the picture, and that's something we need to address when we are managing as well. Men are three pillars, and medicines are not one of them. So, nutrition, very, very important to address. Physical activity, very important to address. And as I said, psychological support or behavioral support is very important. Yes, people can lose weight with calorie deficit. So, a calorie deficit, if you aim for a daily calorie deficit of 500 to 700 calories, you can lose about 5% of your body weight. So, but how long will you stay off it? How long does it stay off? Your body will again compensate to get you back to that weight that it thinks is normal for you. In the audience who know of people who might be diabetics or not diabetics and are using these drugs. So, Akhila set the stage of the psychological and the behavioral aspect, and I'm going to take it forward purely from a dermatologist angle and talk about a few things which still is quite relevant for people when they are using these drugs for just a weight management. So, complex set of drugs, a few graphs, but just for take-home messages so that we can understand both the pharmacological angle as well as a holistic angle. So this is a graph that goes back, as you'll see, to 2018. And I'm just going to share something which is a bit of a funny, because now Akhila said, which year did we start using GLP-1 agonists? Now, I've got a 20-year-old sitting at the back, a second-year medical student, who was in utero when I first attended the GLP-1 talk of exenatide back in 2005. And while I was preparing for my talk, I actually thought, oh my God, this hormone, as Prof. Akhila knows, amylin, has been around since the 1950s. The only thing we couldn't do is get it in a formulation to deliver, because it was destroyed by the gastric acid. So it came out in a drug in 2005, twice a day injection. And this graph actually basically shows that you see the peaked graph is when we have glucose, there's an incretin surge, or these Vigovis and Manjaros, if you can put it that way, is the hormones. At the end of the day, we're endocrinologists, we deal with hormones. And you can see, if that same glucose is given to you in an intravenous fashion, you do not have that effect. So it's an oral effect. And the slide to the right shows how it's blunted in type 2 diabetes. So I'm a diabetologist, I do not do weight management as part of it. So I'm going to speak to you in the next few slides purely about diabetes. So coming from 2005, twice a day injection, it became a once a day injection. And then we used to know our patients skipping it on the day of the barbecues and the things. And then, funnily, I've got a younger child, 12 years old. And around when I was expecting him came the once weekly injection. That's what you remember. After coming back from mat leave, what are the things you need to know to carry on with your work? So the things that is in the press at the moment are the weekly GLP-1 agonist, or the Ozempic. I don't open up BBC News any week without a mention at least 3 times a week of them. The Ozempic faces, Ozempic feet, Ozempic, a lot of other things. How does it work is a question. So GLP-1 is a glucagon-like peptide meaning a protein, which is present in our gut. It works normally. With type 2 diabetes, it comes down, and what we do as endocrinologists is we replace the hormone. Sometimes you can make it that simplistic that we're replacing the hormone. So when we are growing up, we have adequate hormone, and type 2 diabetes hasn't set in. This itself works on the hypothalamus, reduces our appetite, reduces our food intake. It also slows our gut, so we feel full and we don't want to eat. It works on the pancreas and works on the insulin and the glucagon release, which I'm not going to go much in detail for this particular talk. Now, there are 2 examples I always quote as part of any of the talks of these incretin-based things. The point is, human beings are the only animal in the animal kingdom who eat beyond satiety. You will not find a lion who will kill but eat any more than they want to, and then they will move on. And I am very much a human being, I hope so. So I do eat beyond satiety myself.
So I think what we are trying to say here with this hormone, this Ozempics and the Mounjaros is when we replace them, they're working in the thing, they work on the receptors. They go to our hypothalamus and they tell us to eat less. But believe you me, doing this for 20 years as diabetologist, I can see that we can still eat beyond it if you want to. And a standard thing, coming from a South Asian background, I say, your stomach will become this. The question, are you going to put a Mars bar or a jalebi in it? Or are you going to put the healthy stuff, which is what your relationship with food is? So this is how Ozempic works, and in a very similar way, Mounjaro or tirzepatide. So it's a busy slide, but I think it's basically the same. You can see that it works on the hypothalamus to reduce food and calorie intake. It causes a slowing in a gastric emptying. It reduces the hormone glucagon in a glucose dependent manner. Pay 200, 250 pounds a month and afford to lose 20% of their body weight. This is my last slide, again talking about the side effects, the severe side effects which can lead to fluid depletion. And these are the ones that are getting reported. So obviously, if people are using it, whoever uses it from a non-diabetic perspective as well as diabetes, I guess we are trained as clinicians, as registrars, as consultants, or as GPs, because there are a lot of GPs who started to warn people. But the question is with weight management, what is it that is being advised to the people? And that's where inequality comes in. I hand over to Dr. Mallipedhi.
Okay, so we know these drugs work in diabetes. They do work in weight management, but if done in the right way. So these are some quick data from clinical trials looking at their effectiveness in weight management. So semaglutide 2.4 milligrams, more commonly known as Wegovy, achieved a 15% weight loss versus 2.5% with a placebo. Remember, both of these groups had same standard lifestyle intervention. So definitely pharmacotherapy pushes it 4 5 times even more in terms of weight loss. Tirzepatide is 15 milligram, that is Mounjaro in the common world, that achieved an even greater reduction in weight, almost 21% versus 3% in the placebo group. They are effective drugs. And if you go beyond weight loss, the SELECT trial was a cardiovascular outcomes trial which achieved a 20% reduction in major adverse cardiovascular events. So people coming with the first cardiovascular event or hospitalization for a cardiovascular problem was reduced by 20% in people who received semaglutide. And all of these are very, very much validated high level studies published in the New England Journal of Medicine. In addition to glucose control, in addition to weight management, we are also seeing a host of other benefits like reductions in blood pressure, some moderate reduction in lipid parameters, definitely improved quality of life, and many, many more. And we are hearing new things every day. As Shumishta said, we have to be cautious and warn people about the gastrointestinal side effects, nausea, vomiting, constipation. Most importantly, to withhold the drugs if they are unwell or able to, carry on with their normal food or fluid intake. We also watch out very closely under medical monitoring for development of gallbladder disease or rarely pancreatitis. Clinical trials have reported pancreatitis consistently. So anybody with a history of pancreatitis, I don't prescribe these medications as of now. And if any indications, people have to be warned to seek urgent medical advice. We're going to talk a little bit about this loss of lean mass with rapid weight loss, so I'll park that for the moment. I'm also seeing nutritional deficiencies. It's been reported in clinical trials, but more recently in my clinic, because people are coming up to 1.5, 2 years since starting Wegovy when it was first licensed. We are seeing a lot of people having to require folic acid supplementation, iron supplementation, and B12 supplementation. So watch out for those because the calorie intake is significantly reduced. Um, and of course, it's very important. This is why I'm saying they're not wonder drugs, not because they don't achieve what they're supposed to achieve. It's because they have to be given under medical supervision with the right sort of advice and with the right sort of follow up. So, medical review and nutritional monitoring is very, very important. And then the big problem, what happens when it is stopped? So currently, as per NICE guidance, we can only prescribe them for a total of 2 years under the Tier 3 weight management service. So when it stops after 2 years in the NHS or in the private world when people can't afford it anymore, what happens? Clinical trials have shown that there is partial or almost complete regain of weight from baseline. So that is the thing we need to worry about. That is the thing we need to warn our patients about. That they probably are not going to be lifelong medications as of now. And as clinicians, we are putting forth a strong argument to governments saying they should be lifelong medications. We wouldn't stop diabetic medications. We wouldn't stop antihypertensive medications. Why are we stopping these medications, which have shown a host of benefits on their metabolic parameters? But as of now, this is where we are. We are having to stop them abruptly after 2 years. And what are we going to expect? Weight regain. Different, levels, but people will regain weight. Because we know obesity is chronic and relapsing, so ongoing therapy is often required, which is again why lifestyle comes into the picture. And so we have to integrate behavioral and nutritional maintenance plans along with pharmacotherapy and have support systems, which again is missing at present. And again, this is where your comp comes into picture. It is assessing the capacity, making sure people have complete understanding and motivation to carry on with what they have managed to achieve so far. Because currently, my cohort of patients who are going to come off these medications after a 2 year cycle are in absolute panic, saying, "You're going to discharge us from these clinics. We are not going to have the medications. What's going to happen to us? Where do we go?" We have to discharge them because we have to see new people. So it is a very tricky situation at present. And I'll finish off with this quick slide that Shamishta showed me, and it's very interesting, where this was a study where they hypothesized what would happen if we integrated resistance-based exercise in addition to GLP-1 therapy. As I said, people lose lean body mass, people lose muscle along with fat when they go onto these medications. So what they are postulating is if you stand as a standard procedure, ask people to do resistance-based exercise along with pharmacotherapy, will we be able to offset some of the problems that people face? So I don't know how clear it is to the people at the back, but basically incretin therapy can be associated with significant loss in lean body mass. We know that from studies. So if you look at the graph on the top left, there is a drop of about 17 kilos with incretin therapy at week 72, and in the placebo group, there is a drop of about 4.2 kilos, so 4 times more weight loss. And when you look at the lean body mass on the top right, there's almost a 4 times increase in lean body mass loss as well. So they lost about 1.4 kilograms equivalent of muscle in the placebo group, whereas in the incretin therapy group, they lost about 6 kilos of muscle. And what they're saying is within 72 weeks, so 1.5 years, they're losing almost a decade's worth of muscle mass, age-related muscle mass. So it's something significant to think about and to warn on the people who are going on to these medications. So what they did is combined the knowledge achieved from two different aspects. One, this side, the white side, is all the evidence that they have from pooled studies on GLP-1s, and the part in the gray area is the predicted hypothesis of what can happen if you add resistance exercise into the picture. So these are hypothesized, the graphs at the bottom, and what they're saying is if you add, so the blue line on the graph is incretin therapy only, the orange line on the graph is if you add resistance exercise to incretin therapy. So people who don't have resistance exercise as a standard, 66% regain. People who have had resistance exercise as a standard, only 12% regain. So there's a big gap there. So hopefully you're able to blunt the amount of weight regain. Otherwise, what is happening is people are regaining all this, but what they're regaining is not muscle, they're mostly regaining fat. So if they're back to baseline, after you've stopped these medications, they're actually much worse off because they've lost all that muscle and regained more fat composition. So their body composition has changed for the worse. So something to think about. And this is the core of today's talk: is these medications are new. They're great medications, don't get me wrong. I use them in my diabetes clinic, I use them in weight, but I don't think we know them enough to be giving them out like Smarties yet. We don't have long term global data, and we need to wait to see how they're going to affect cognition, how they're going to affect nutrition, frailty in the long term. So, pharmacotherapy, yes, is a small tool that we use, but in association with lifestyle, psychological, and social support, also to address stress, sleep, mental health, and environment, community and cultural engagement. And the goal is not just weight reduction and appearance, it is important to emphasize the quality of life and metabolic health, reduce cardiovascular risk, and so on. So I'll stop there, and I'm happy to take any questions.
Do we have any questions? Yes, Laura.
Thank you. Well, thank you for an absolutely fascinating talk, really quite superb. A concern that I've had for a long time has been about children, children's well-being and the whole problem of prevention, and the evidence that if when people are obese in early childhood, then actually it's a disaster for the rest of their lives. And I just wonder what you feel we should be doing differently to, for example, make sure that on every high street there are fresh vegetables rather than processed foods. Should we be actually saying if you have a vegetable shop, you don't pay commercial rates to encourage those shops and get rid of betting shops and booze shops? Because one of the problems too is that I know there are some people who don't drink, but the calorie count in alcohol is really high. And the other problem that I see in young teenagers in particular and adults is the evidence that artificial sweeteners actually promote appetite. And so you're physiologically, you think you're going to have a sugar load, but actually you don't get the calories, but you get the hunger that goes with a deficit. And similarly with chewing gum. And should we actually just be addressing those through childhood? Because I've been astonished the number of people who think that zero Coke is healthier. And you think that no sugar chewing gum will stop them putting on weight. And they are all just getting bigger and bigger.
I, there are a lot of people who are more clever and experienced than me in giving solutions. But I was thinking of bringing up 2 points. It's very important. There's no very limited obesity or weight management service for children and young adults. Many of our health boards in Wales don't have a young adult service to manage diabetes or obesity, and that's a big worry. As you said, I'll tell from my experience in my adult weight management clinics, as you rightly said, hit the nail on the head. Most of the problems start at that point where the child becomes a teenager. They reduce playing sport, they're exposed to fad foods, social media, and so on. That's also where somewhere we are not looking after our children's mental health, because that's playing a big role. There's a lot of emotional abuse, they quote bullying, and that's where things are changing and the cycle is starting. And then we are addressing it in the 40s and 50s. But I'll pass it on to my colleagues if they want to come up with solutions.
We know that children with obesity perform less well in school, their academic achievements are poorer, they're less likely to be employed than children of normal weight. So it's not just the food that's the issue and how obese they get as adults. I think it has to start with how we begin feeding our children from toddler age group and how to nurse them to the healthy start groups, which are not as well funded as they used to be. School dinners are dreadful. And talking about inequalities, I have to get, for my son to eat healthily in school, I have to give him a packed lunch, which costs money and it costs more than giving him school meals. But the school meals that are provided even in fairly affluent areas of Cardiff, is, and I've eaten it when I visited schools to do open days, it's awful. And what's available as snacks for playtime are bagels, waffles, bacon sandwiches is high sugar, but it feeds into the local economy as well. Why aren't we eating fresh food locally with local providers, and not why it's not cooked in on site? There's also sports, and we know that children do better. Um, their vision is better when they're out playing sports outside. They don't, and they're less likely to become short-sighted. So again, it's not about food, it's about academic achievement, how they do better in school, and providing all the children in Wales with the ability to play sports. And then it comes to body images as teenagers and girls and social media, and children who live in more socially deprived areas are more likely to be bombarded with adverts for poor food, etc. So it starts at that point.
The majority of them are type 1. But it's scary when I see the type 2s coming through. And I think I'd like to go back to the previous talk. It's not about man's health, woman's health. It's a family health. And I think that is whether it's a mother, whether it's a father, and it's what we get. I've been 25 years in the country. I'm sure there are lots of people who've been here longer. So we have come from a potato-based country, which was a staple, isn't it, to food has moved. And I guess that is where the government policies have to come in. You can still walk out, and the cheapest food is the most calorie-rich food. College going, university going child, and again I see what's the easiest to eat out there. Now, obviously, we put warnings on our cigarettes to say it kills, but it's a mindset. And yes, it's a mindset that we're all crossing, and it is a big worry. There is actually a GLP-1 agonist, which is the only licensed one for teenagers, and it's sad that we have to learn it.
I just want to agree with the lady next to me, but I want to say that we really do need to start at the very beginning, and that's antenatally and with breastfeeding, because breastfeeding is a miracle in that it provides all the nutrition that the child needs and lifelong benefits, and it also reduces the weight naturally that the mother needs to lose after she no longer is carrying the baby. We're absolutely abysmal at it. You know, people go into hospital saying they want to breastfeed and they come out not breastfeeding, feeling guilty just because they haven't had the support they need. And we just don't have enough people to support women to who both want to breastfeed and know that they have to breastfeed if they are poor, because if we are not helping people who are on low incomes to breastfeed, we are condemning them to enter the criminal justice system, because the Healthy Start voucher doesn't even cover one tin of infant formula. And that is why you'll see it locked up in cupboards in some supermarkets, because people are having to steal it because they've failed to be helped to breastfeed and now they don't have other options. This is a completely grim story.
Um, I think all the important points have been made, and as you say, you need to really think differently, like vegetable shops and things. And one of the ideas which has always been rumbling in my mind is we all use the smartwatch, we all use our mobile phones, lot of people like to go to gym, and I think instead of putting the calories or steps to count, we should just convert into the food. A packet of crisp appears and you walk on your treadmill and you slowly start going down. That's when you realize that eating a packet of crisp was a bad idea. Same thing you can do with your smartphone. I think fasting is one of the sort of field which we haven't really fully utilized for the weight management. And Minaji has specifically asked me to just give a little bit of experience with, because I'm a qualified yoga teacher. So I think we have been sort of, we know about yoga and pranayama, and there is the emerging evidence suggests that there are breathing exercises and yogasanas which does help you to reduce the weight by number of mechanisms. Because when Akhila was speaking, it was a music to my ear because it was all the things about lifestyle changing and stress. The stress plays a very important role in putting the weight because it will increase your appetite, it will make your body store more fat, it will reduce your sleep, it will also increase your blood sugar and reduce your metabolism. And I think the lifestyle measures, particularly those who can reduce the stress. I mean, yoga and pranayama is my favorite, but whatever is your favorite, reduce the stress, and hopefully that will help the weight management in a very effective but profound way. Thank you.
Thank you.
Mina has lots of
And the last question, how can weight management programs can be culturally adapted for different communities?
Uh, the weight management program for different communities need to be adapted according to the norms and culture and various things. I mean, one of the simplest thing would be somebody to write a book because we see so many books about the healthy dishes. I think one should write a book about saying the healthy Diwali dishes, or one should do more research onto the the Ramadan fasting and highlight the health benefits of Ramadan fasting and put some scientific impetus behind it because that would inspire more people to use them as a health related tools rather than simply a religious rituals. I mean, as I said, fasting is one of the things which is there in almost every culture, and we need to highlight the importance of it for the weight management, and that's why we need to adapt according to every culture differently.
Briefly, sorry, I think you're right. It's to do with adapting for every culture and emphasising what both of you said. It's not about weight loss, and at the minute there's lots of cultural and lots of socially deprived areas who completely focus on weight loss as being a static type of thing. And it's the same thing with men's health and having that quick fix muscle bound body with performance enhancing drugs in the valleys. It's the same thing. There's lots of our patients and staff members who are on Manjaro in the area because it's a quick fix. It's embedding it in the culture and ensuring that people know it's a lifestyle change as opposed to being a quick fix for now.
Can I say something quickly? I don't think we can be prescriptive about diets as much as I said, yes, we should understand cultural and social factors. So it's very important again to bring in family members, communities, go out there and educate general awareness. It's very difficult to be prescriptive because there's so many varieties, so many cultures out there. I think it's about dealing with food behaviors and eating habits, how to deal with the food noise, because that is what is happening when they come off medication or when they come off the diets. The food noise comes back with a vengeance. How do you deal with it? And that's what our clinical psychologists are experts at, to say how to cope. It's never, nobody's going to say it'll never come back to you. You'll never have that craving for Diwali sweets. Yes, you eat on Diwali, but you compensate for that after that. So it's all about energy balance, understanding how to balance that energy expenditure. And like you said, maybe intermittent fasting, having some sort of a principle in life to compensate for those days when we overindulge. And I think it's just working around our food psychology is most important because let's be honest, we don't like prescriptive diets, isn't it? I don't like it when somebody, you have to make this or you have to eat it. We all have our a lot of emotions, happiness, satisfaction related to food. So yes, you eat what you want, but as long as you're curtailing the quantities to an extent, variety is important in life, and that's something our psychologists and dietitians do say, is to keep it as varied as possible as well. um,
I forgot what else I wanted.